Good evening, everybody. On behalf of the Asia Pac Leukemia Consortium, we welcome you to our clinical update series. And for tonight, we'll be doing clinical updates in chronic lymphocytic leukemia. We will focus in our Southeast Asian countries. We have a very exciting evening program tonight with very capable chair, speaker, and panelists. And before we go on to the meeting proper, maybe I start off with a brief word of introduction on what is the Asia Pac Leukemia Consortium about. So next slide, please. So why Asia Pac? Well, members highlighted that there's a need for the leukemia and related disease study group because there's a lot of unmet needs, and we need to drive initiatives across the region. We chose leukemia because leukemia, I think we feel is the area where there's a fair bit of unmet needs, but we also encompass related diseases, which means the other heme malignancies as well. For Asia Pacific, as we know, is the largest population group within the world. lot of rich resources, very large heterogeneous population with lots of opportunities, and as mentioned, unmet needs. And of course, Southeast Asia is the integral part of Asia Pacific. We also know that there's relatively low costs involved and a very attractive region for conducting very good clinical research. And I think more and more, I think we are seeing that companies are choosing to come to this region. So I feel that the time is opportune now to actually tap on the resources that we have and form a consortium. Next slide, please. So our mission statement is to actually improve the management of leukemia and related diseases through collaborative effort of valued partners, which include industry, academia, and so forth, through a multi-targeted approach, bench, bedside, and translation of real-world evidence and bioresources. Next slide, please. So this is a very brief overview of our timeline. We are very new consortium. We have barely started like 1-2 years ago, and we took some time to decide what is the format, what is the name, decide on the constitution, the model of setup, and the legal framework. Then we finally have sort of more or less 1 year ago decided on our format of our current meeting, and we are still in the process of actually getting our members and getting our various groups, working groups in order. So we are still in a very nascent process of startup, but we have a few educations, our second in our series of education seminar. Next in line, next slide, please. And our focus areas are clinical trials, disease registry, tissue and genetic repository, education, patient advocacy, and care. So these are our 5 main focus areas, and we have leads for each of them. Next one. And we have core memberships from most of the major countries within Asia Pacific, with a very, very experienced group of core leaders leading the consortium. Next slide, please. So with that very brief introduction, if there's any questions, we welcome you all to email or contact us. And without further ado, I'll hand you over to our chairperson. It's bringing me great privilege to introduce my good friend, Dr. Ng Soo Chin from Subang Jaya Medical Center, who is also our founding EXCO member as well as our patient advocacy lead for APLC. So I'll hand over the evening to Soo Chin to take over. Soo Chin.
Thanks very much, Professor Goh, and I would like to welcome everybody to this evening's CLL talk. Our program today consists of the highlight lecture from Prof. Kon Tam on update in CLL. There will also be some panel discussion on case series, and I would like to welcome the participants to submit their question through Q&A chat box at throughout the discussion. Before we start, we just like to go through some poll questions to set the platform for Prof. Tam's talk. Yes, would like you all to vote. Do you test your CLL patient routinely for del-17p prior to starting treatment? First response would be yes, routinely for treatment-naive CLL patient. Second, yes, only for relapsed refractory CLL patient. 3, no, because I have no access to del-17p FISH test, which is a real problem in some countries. Number 4, no, I test only if BTKI or novel therapy is being considered. Please vote. So we wait for the answers to come in anytime now. Yes. So I think testing is an important part of the management of CLL patients. So we do want to know in different countries what are the facilities available, and if at all these tests are being done and at what stage of the management of the patient. Yes. Wow. Of the four who voted, I think they say that it's routinely for treatment-naive CL patient. So that's we have other coming in. 25% say they have no access to del7P fish test. Would there be any changes still? So that just gives us a favor that in some countries the fish test for del7P is readily available and is given even at the early stage part of CL patients. Or some countries have absolutely no access to del7P fish test. So there's a gap in the testing availability. Yes, we move on to the next poll. Do you test your CL patient routinely for IGHV mutation status prior to starting treatment? 1, yes, routinely for treatment-naive CL patient. 2, yes, only for relapsed refractory CL patient. 3, no, because I have no access to del17P fish test. No, I think it should be the earlier one, IGHV mutation test. No, I test only if BTKI novel therapy is being considered. So again, we want to know how widely available the test IGHV mutation is done in our part of the world. Yeah. Yes. 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 Okay. Okay, we do have more widely distributed kind of results. So routinely in 50% of the respondents, no, because there is no access to IGHV mutation test, 25%, and 25% think that they will test only if the BTKI therapy or other novel therapy is being considered. Thanks. I think that. So there's. Yes. So we move on to the next question. So question number 3. In your clinical practice, what percentage of your treatment-naive CLL patients are initiated with chemoimmunotherapy? First will be less than 10%. Second will be 10 to 25%. 3 will be 25 to 50%. Fourth, 50 to 75%. And last will be more than 75%. We all know that chemoimmunotherapy started off as the main mode of therapy some years ago. Now with targeted treatment, novel agents, and so forth, we would like to see what is the impact of the new therapy in our standard practice. Whether chemotherapy, immunotherapy is still the mainstay of treatment, or the use has been eroded. Yes. Yes. Okay. So we can see that what percentage of your patient. So the chemoimmunotherapy still remain the mainstay of treatment in 50% of the participants in respondents, and 25% and one quarter each will be 10 to 25%, and now 40% of 25 to 40%. So I think it's almost running neck to neck now in some places, chemoimmunotherapy versus targeted therapy. Yes, I believe. So we move on to the last poll question. In your clinical practice, what percentage of your patient or treatment-naive CLL patients are initiated with BTKI inhibitor? Less than 10%, 10 to 25%, 25 to 50%, 50 to 75%, and lastly, more than 75%. So we want to see how big an impact the BTKI inhibitor can make in the initial first-line treatment of CLL. Well, at the moment, what we have is 100% of the respondents think that less than 10% of their treatment-naive CLL patients are initiated with BTKI therapy. So you could really, as there's still a lot of room for growth for BTKI in this part of the world. The other way of looking at it is BTKI therapy is still not a popular choice, at least not yet. So there's now a more balanced kind of view, 33%, 25% of respondents say that 10 to 25% of their initial treatment-naive CLL patients are initiated with BTKI therapy. Okay, so we are finishing with 20 versus 80. So I think we are done with the poll. And it gives me great pleasure to just say a few words about Professor Contem, who is currently the head of lymphoma service at the Alfred Health and professor of hematology at Monash University. Before that, Professor had obtained his MBBS honors from University of Melbourne. He did a stint in MD Anderson before he served more than 10 years at Peter MacCallum Cancer Centre and Royal Melbourne Hospital. Professor Tam is well known for his innovative new treatment for blood cancers, and his among his achievements were the initiation of ibrutinib and also the combination of ibrutinib and venetoclax combination. He did pioneering work for that. He's a prolific researcher, and with 240 peer-reviewed papers in high-impact journals. His work is highly cited, and he's also the current lymphoma editor for Blood Advances. Without further ado, I would like to call upon Professor Contem to deliver his lecture this evening on updates in chronic lymphocytic leukemia. Professor Tam.
Thank you, Ev. Thank you for the very kind invitation to be here with you tonight. Due to COVID, I'm not able to travel, but I hope very soon to see all of you again in Southeast Asia. And I'm so happy to see this very important consortium being set up. And I wish you the very best in your successes. So my job tonight is to talk about clinical updates in CLL. So I will probably start by just some basics, which I'm sure is well known to this audience. So CLL is actually quite rare in Asia, but it's the most common leukemia seen in my region in the Western world. Most patients, as you know, are diagnosed incidentally. Most patients are older, and many patients at the time of diagnosis do not show signs of advanced disease like lymphadenopathy, hepatosplenomegaly, B symptoms, or bone marrow failure. And of course, it's said to be incurable, but about half the patients never require therapy. This is CLL on the blood film with some prolymphocytes as well as small mature lymphocytes, and then has a very characteristic flow cytometry pattern, which is diagnostic of this disorder being a CD5, CD19, CD23 disease. So, as we mentioned before, most of you still use chemoimmunotherapy for CLL, and in fact, we still use chemoimmunotherapy these days for some of our patients. And in fact, FCR, which is the frontline immunotherapy most commonly used in CLL, is really good treatment. And I just wanted, before we go into novel agents, I want to just remind you of the results of FCR. So this is a paper that I was very lucky to have been involved with when I first went to MD Anderson in 2006. And this has been updated by my colleague, Phil Thompson. And these were the original 300 patients treated at MD Anderson with FCR as frontline therapy. And you can see that the time axis in here is years. So this is talking about 15 years of follow-up on these patients. This is not, 15 months of follow-up as we get in a lot of papers. This is, decades of follow-up. And you can see that, and this is progression-free survival. And you can see that for patients who are IGHV mutated, in fact, there's a cure fraction with FCR chemoimmunotherapy. And about half the patients actually never relapse after FCR. So for patients who are unmutated, although the results are inferior to those who are mutated, you can see that the median progression-free survival is still not bad at somewhere between 4 to 5 years. So although these days we try to avoid FCR chemotherapy where possible, it is in fact really good therapy for CLL. It's 6 months of treatment. If you're IGVH mutated, there's actually not a bad chance you're cured of your CLL. And if you're IGVH unmutated, you will still get years of remission. So I just want to put this in context before we talk about all the sexy new drugs. So as you can see here, FCR was proven to be superior to bendamustine rituximab in this German CLL-10 study. And we know, of course, that the bugbear of FCR chemotherapy, or indeed any chemotherapy, is 17p deletion. So even back in the year 2000, when Donor first published this paper on fish chromosomes in CLL, and this is before fludarabine, before rituximab, even back then, we can see that the 17p deleted patients in the green curve do very poorly. And we now know that 17p deletion is due to a deletion of the p53 gene. But of course, the p53 gene can be knocked out by both a deletion as detected by FISH or also by a mutation as detected by sequencing. And we now know that if you have a mutation in p53, then you do just as bad as a FISH deletion of 17p. So this is an important point because it means that really, if you're going to start someone on chemoimmunotherapy, in the ideal world where all your tests are available and you've got unlimited resources, you should really be testing patients both by FISH for p53 deletion and by sequencing for p53 mutation, because you can get a deletion without mutation, and you can get mutation without a deletion. Uncommon, but you can get people who have only got one without the other, and they do just as badly. Now, if you can't get sequencing, it's not end of the world, because the FISH test will still probably pick up about 80% or 70 or 80% of the patients with a p53 abnormal pathway. As you know, the prevalence of a p53 abnormality increases depending on where you are in the disease stage. It's fairly uncommon at the time of diagnosis. It's about 10% at the time of first-line therapy. By the time it becomes refractory to fludarabine, it's about 30%, and it reaches to about 50% by the time you are refractory to multiple drugs. So although FCR is a wonderful drug and I respect it and I love it, there are a few problems. So for a start, it's mainly practical in young patients. In my hands, I would be happy to use FCR up to 75, maybe 77 years old, but most patients will stop at about 70 for FCR. And you have to have pretty good renal function because fludarabine is excreted renally. You can get, as you know, prolonged cytopenias and you can get opportunistic infections. There is a general feeling that if you re-expose someone again and again to chemotherapy, that you may induce a p53 abnormality. But I put some question marks there, as this is a bit of a controversial topic. But I think the final point is most important. And this is the point that I always discuss with my patients when I prescribe FCR chemotherapy, is that there's a 3% risk of MDS and AML, which may in fact be worse than the original CLL. So these days, for my patients who are unmutated in RGVH, where there's no prospective cure, I try to use a novel agent where a novel agent is available, just to avoid this MDS risk. For patients who have RGVH mutated disease, where there's a prospect of a cure, then we come down and say, look, do you want to go for a potential curative regimen with 3% risk of MDS or AML, or do you want to go for a non-curative regimen where the risk of myelodysplasia is not increased above baseline? So this is probably one of the most important statistics that I discuss with my patients when I choose therapy. Okay, now that we've touched base on the background history of chemotherapy and FCR, I want to talk about the successes in targeted therapies. And really, I put these two columns up side by side because these two groups of drugs, ibrutinib or the BTK inhibitors and venetoclax or the BCL2 inhibitors, really were developed side by side simultaneously. And I keep on saying to my patients, if you tell me back in, let's say, 2010, that we're going to have two classes of drugs, which are both oral, which have both got minimal side effects, is effective against 17p CLL, and it's highly effective, I would say you're dreaming. But in fact, not only do we have one class of drug in that time, we've now developed two classes of drug, which both work really well, and the development happens simultaneously. So let's talk about the BTK inhibitors to start with. And whenever I talk about BTK inhibitors, I find it useful to think about the human disease where BTK is missing. And this is a disease called Bruton's agammaglobulinemia, described by Colonel Bruton in 1952, when he noticed that boys were being born with no B cells and no immunoglobulin. And we now know that this disease is due to a mutation of BTK on the X chromosome. So it's an X-linked disease because it's a mutation of BTK on the X chromosome. These are boys who are born with no circulating B cells, they've got small lymphoid organs, and they have severe hypogammaglobulinemia, and they get frequent bacterial infections. But if you replace the immunoglobulins, these kids survive in the mid-adulthood. So why do I like to think about the pediatric disease? I like to think about it for two reasons. Firstly, the pediatric disease showed us that BTK is indispensable for B cell development. If you don't have BTK, you will not get B cell development. And of course, CLL is a B cell disease. The second reason why I think the pediatric disease is useful is because patients always worry about long-term drug therapy. And when you start someone on a BTK inhibitor, they're stuck on it for life. So, I've got patients who started ibrutinib back in 2012, who is now coming into the 10th year of therapy. And they ask me, what side effects can I expect in the future? Am I going to have organ damage? And I say, look, probably not, because we know that this enzyme can be absent in a human in a pediatric disease. And apart from having no B cells, these humans are in general pretty normal. So that's reassuring that this is a great target for long-term blockade. I'm sure all of us have used some BTK inhibitor, and as you know, your response is dramatic. So often patients, even after taking the first dose, notice that the glands are getting softer, and then over a period of weeks to months, they get complete resolution of the lymphadenopathy. And probably my first contact with BTK inhibitors was when we approached the company to say, you must make this drug accessible to Australian patients because it's so powerful. and we're invited to join the RESONATE study, which is a study in relapsed CLL comparing ibrutinib, the BTK inhibitor, versus an antibody called ofatumumab, which back in 2012 was considered the standard of care for patients with multiple relapsed CLL. Well, it doesn't really take a major degree in mathematics to see on the left here that ofatumumab really didn't do very well compared to ibrutinib. So this is long-term follow-up of this study showing that ibrutinib on average in this very, very heavily pretreated group of patients gave us about 4-year progression-free survival, whereas for ofatumumab, the progression-free survival can be measured in days. Now, the other observation from this study was that the earlier you use a BTK inhibitor, the better you do. So the progression-free survival for patients who receive ibrutinib as their first salvage, so someone who just failed FCR and go on to ibrutinib, is very good. And conversely, we give it to multiple relapsed patients, the responses are less good. So one of the lessons learned is that you probably should try and use this drug at the earlier stage, because the earlier you use it, the better the outcomes. What about p53 mutation? And the red line here is a progression-free survival with p53 mutation, which is still not quite as good. A patient without p53 mutation, but in general, is pretty good for this population. This is like the best results we've seen so far in this very difficult to treat population. An interesting observation with ibrutinib is that 11q deletion, which previously was a bad prognosis back in the chemotherapy age, has completely disappeared, and patients with unmutated disease did just as well as patients with mutated RGVH. So ibrutinib really neutralized many of the adverse risk factors that we think about in CLL, with the perhaps exception of deletion 17p, which continues to be very mildly prognostic, usually in the heavily pre-treated setting, and patients with frontline 17p these days actually do very well by ibrutinib. So it's a nice drug to have because you don't really need to think about your prognostic risk factors when you start this drug. Long-term outcome of ibrutinib in 17p CLL, you can see that this is across all the relapse refractory studies. You're looking at median remission of somewhere between around 2.5 to 3 years. And of course, if you use this in the front line, you get an even better outcome. So since then, ibrutinib has been compared against chemotherapy. So it was compared against chlorambucil, and someone say this is not a very fair context. You can see that ibrutinib is superior to chlorambucil. It was compared in the Alliance study against bendamustine rituximab, and once again, ibrutinib was a better drug. And then most convincingly, there are now 2 phase 2-3 studies comparing ibrutinib to FCR. This is the ECOG 1912 study from the US. There's a similar study from the UK, and both studies show that ibrutinib was a better drug compared to chemotherapy. So really, ibrutinib has been compared against chemotherapy in both in the very old patients, in the semi-old patients, and the young fit patients. And in every comparison, ibrutinib has come out on top. So just to summarize, the ibrutinib phase 3s is better than FCR, better than bendamustine, and better than chlorambucil. The main benefit is in patients with unmutated RGHV, because these patients do pretty well with chemotherapy. I didn't mention this, but there is a cardiac signal in older patients, which I'll touch on a bit later. So patients do have atrial fibrillation, and there's a risk of ventricular arrhythmias. And then there are a couple of other side effects of ibrutinib, which I'll talk about, including bleeding, diarrhea, rash, and arthralgias. So for those of you who have used ibrutinib, you will know this very well. I'm just showing this for some of you who may be about to use it for the first time. So if you use a BTK inhibitor, you will see within hours of starting the first dose that the white cells will go up very high. So this is a patient who starts on the BTK inhibitor, and at 1 month and 2 months, you get a very marked rise in the lymphocytes in the blood. This is the way that the drug works. It pushes the cells out from the bone marrow and the spleen into the periphery. And at the same time as the white cells going up, you see the lymph nodes shrink down very nicely. And the patient will tell you to feel very well. So do not be afraid to see a very high white cell count shortly starting a BTK inhibitor. This is normal, and do not stop the drug, because this is not progressive disease. This is just the way the drug works. Compared with chemotherapy, BTK inhibitors are very useful because they don't exacerbate myelosuppression. They are not myelosuppressive on the whole. The major side effects are bleeding in about half the patients, and atrial fibrillation are said about 5 to 10% of patients, but in fact, it's more like 15%. So this is the sort of bleeding that we get. So this is a patient of mine who has a bleeding, and very unusual bleeding site on the palm. And this patient was on ibrutinib, aspirin, and clopidogrel. Now, I'm about to tell you that ibrutinib is probably the most potent antiplatelet drug ever discovered. So it is a very, very potent antiplatelet drug. So as you can see, this patient was in fact on triple antiplatelet drugs with ibrutinib, aspirin, and clopidogrel. And when I stopped the clopidogrel in this patient, there's no further bleeding. So be very careful when you use ibrutinib in combination with other antiplatelet drugs. You must stop the drug before surgery. Both of these patients did not stop the drug before they had skin surgery on the forehead, and both these patients bled for days after surgery and did not stop bleeding until they stopped the ibrutinib and had a platelet transfusion. So you must stop the drug before surgery. And I don't have the slide here, but the mechanism of bleeding for ibrutinib is that it stops collagen activation of platelets. So the collagen receptor on the platelet is glycoprotein 6, and that depends on BTK for signaling. I mentioned before that ibrutinib causes atrial fibrillation. We published this paper in 2014 when we noticed that there seemed to be an AF signal in ibrutinib at about 5 to 10%, and every phase 3 comparison ever since then of anything against ibrutinib has shown an increased risk of atrial fibrillation with ibrutinib. We don't fully understand why, but it's something to be aware of. There is also a new signal. So we think that atrial fibrillation is the tip of the iceberg. So patients who got, there are some patients who in fact get ventricular arrhythmias and sudden death on ibrutinib. And we think the risk of that is about 1 in 200 patients. So ibrutinib, major problems, bleeding because it's an antiplatelet drug, and cardiac arrhythmias because it causes atrial fibrillation and ventricular arrhythmias. Now, I will show you data later just to show you that the more specific BTK inhibitors, such as acalabrutinib and zanubrutinib, are much safer in terms of cardiac toxicity for much lower risk of atrial fibrillation. So let's talk about acalabrutinib or ACP-196. This is the main difference between acalabrutinib and ibrutinib is that acalabrutinib is very clean. You can see the Canon profile of acalabrutinib here compared to ibrutinib, which is really dirty. Now, you remember I said that there are boys who are born without BTK. Okay, so these are boys who do not have BTK in the body, but they don't get cardiac arrhythmias. So why do people on ibrutinib get cardiac arrhythmias? And for me, the reason why is because of these off-target effects, because the drug is very dirty and hits other enzymes, which can affect the heart. Precisely which one, we do not know. What we do know is that the more specific the inhibitor, such as acalabrutinib or zanubrutinib, the lower the risk of cardiac arrhythmias. So the main advantage of the new drugs, the new BTK inhibitors, are that they cause less cardiac arrhythmias. So this is the ELEVATE study, which compared acalabrutinib versus chlorambucil obinutuzumab in older patients in the frontline study. And what this study had 3 arms. It had acalabrutinib, a lone arm in green, acalabrutinib plus obinutuzumab arm in red, and the control arm is in blue. And you can see that acalabrutinib is highly effective as a frontline therapy for CLL. It can be given with or without obinutuzumab. In my own practice, I give it without obinutuzumab, and the drug does work very well, just like ibrutinib. Importantly, just like ibrutinib, you can see that even in patients who've got 17p deletion or mutated p53, they've got very good outcomes. And in fact, acalabrutinib has been compared head-to-head against ibrutinib in the phase 3 study. So I've mentioned that it feels like acalabrutinib is an easier drug to give than ibrutinib. It feels like the rate of atrial fibrillation is lower. Well, this is a study that proved it. This is a phase 3 head-to-head study in relapsed refractory CLL. So in this study, which looked at patients with high-risk disease, so you have to have a 17p deletion or 11q deletion, and you have to have relapsed CLL to enter this study. The progression-free survival for the two drugs is identical. So acalabrutinib is just as good as ibrutinib. But the rate of atrial fibrillation and flutter, as you can see, yellow here in ibrutinib and blue here in acalabrutinib, is much lower by acalabrutinib, being the more specific drug. And also the rate of hypertension is lower. Now, we think that hypertension is actually a very major side effect of BTK inhibitor therapies. And indeed, patients who have long-term BTK inhibitor therapies tend to get hypertension, which is also a major risk factor for atrial fibrillation. So cardiovascular risk is a very important part of management of BTK inhibitors these days. You can see that the more specific drug, acalabrutinib, also reduced the risk of bleeding events, diarrhea, and arthralgia. So the specific inhibitors work just as well with less side effect is a major message. So BTKI are now a standard of care in frontline and relapse refractory CLL. The major limiting factors are bleeding, arrhythmia, and hypertension. And the second generation drugs have reduced side effects compared to ibrutinib. I'm going to touch very quickly on BCL2 inhibitor because I know my time is short. So I just want to show you these because these are the first 3 patients in the world to be treated with venetoclax. And they were treated in Melbourne at Peter Mac. And you can see that what we see here is in the red line is the white cell count, and in the blue line is the LDH reading. And this is before the drug at 8 hours, 1, 2, and 3. Now, for those of you who have used venetoclax, you know that our starting dose is 20 milligrams. Back then, based on the phase 1 animal experiment, we thought that the starting dose was 200 milligrams. So the first 2 patients in the world got 200 milligrams of venetoclax, and they both tumoralized, as you can see on the graph there. They both survived, but they both tumoralized. We then reduced the dose to 100 milligrams, and that one also tumoralized. So venetoclax is an extremely effective drug. It causes immediate tumor lysis syndrome if given in high doses, and it must be dose escalated. But this just illustrates how powerful this drug is. So this is a paper from my colleague Andrew Roberts and John Seymour of the phase 1 study of venetoclax showing a very marked reduction in disease in patients with highly refractory CLL. And then these patients, venetoclax has now been compared in the frontline setting for patients with CLL, and this is a CLL14 study, a frontline study comparing venetoclax-based treatment, venetoclax obinutuzumab, versus chlorambucil obinutuzumab. And what this study showed was that venetoclax obinutuzumab had a very good progression-free survival compared to chlorambucil obinutuzumab. And in fact, when we look at this progression-free survival curve, which is in older patients, so these are patients who are unfit for FCR, you say this curve looks pretty similar to FCR in younger patients. And indeed, I'll show you data later to show that this drug, venetoclax obinutuzumab as a regimen, is probably better than FCR as a frontline treatment. The main drawback of this regimen is that patients with p53 abnormalities in the solid blue line here continue to do a little bit worse than those without p53 abnormalities. If you do the same study using BTK in the front line, p53 is usually not a risk factor for BTK therapy in the front line, but it does matter for venetoclax. They do slightly inferior. Similarly, for RGVH unmutated patients, they do slightly inferior with venetoclax-based treatment, whereas for BTKI-based treatment, there's usually no difference between RGVH mutated and unmutated. I'll skip that. So very quickly touch base to say that there has been a 4-way randomized study done in fit patients comparing FCR-based chemotherapy versus GV, which is obinutuzumab venetoclax, the one that I just talked about in older patients, versus this regimen plus ibrutinib, so hamburger with a lot. And what this study showed is that in the red curve, these patients who got obinutuzumab venetoclax did really very well, and they actually did even better than those patients who got FCR. So we now know that venetoclax obinutuzumab is probably at least as good as chemotherapy. But the most disappointing and interesting thing about this study is when you add ibrutinib to GV, which is a very expensive regimen, you can see that they don't do that much better than GV by itself. So I think that GV as a time-limited regimen, because you can give it for 12 months and stop it, is going to be very hard to beat as a frontline regimen for patients with CLL. So this is my last slide, and my apologies going to be over time. But the BCL2 inhibitors, so different from BTKs, are clearly active and proven to be superior to chemotherapy in both the frontline and relapse settings. The main drawback to this group of therapy, which is time limited, and that's the advantage, you can give just a set duration of therapy rather than indefinite therapy. The main drawback is the logistics of tumor lysis monitoring, which can be difficult even in countries where we have got very good healthcare and access to real-time laboratories. And just to say that the BCL2 inhibitors may be inferior to BTKI in the frontline in patients who've got 17p CLL and RGBH unmutated disease. Whereas if you use a BTK inhibitor, although it's indefinite, the tumor lysis monitoring is basically not required because it's very rare to get tumor lysis with BTKI, and BTKI pretty much ignores these prognostic factors, so you can give it without thinking very much about the prognostic factors. And with that, I'd like to thank you for your attention.
Thanks very much to Professor Contem for a highly informative lecture actually, I think you are within time, well within time. Let's see whether we have any questions. Well, the lecture is so clear that at this moment in time, there are no questions from the audience. So good job. Prof. Goh, you want to say anything? Any burning question from your side?
No, I think it's very, very clear, but I think it's quite apparent from the response that our Southeast Asian colleagues, there's quite a fair bit of chemoimmunotherapy. I was a bit shocked. Maybe Con can share that there's quite a lot of chemoimmunotherapy being used in this BTK era, and part of it could be a reflection of access to testing, IGHV as well, or 17p or TP53 testing. So, Con, if we don't have access to testing and we don't know the mutation status, some people have said that it's better then to start all patients on the BTKI.
Yeah.
Would you agree to that statement, or?
Yeah, so I think the main advantage with BTKI is that it works no matter what your prognostic factors are. So BTKI tends to ignore, especially in the front line. So in the patient, in the original, in the original Resonate study, which was done in really, really awful patients, there was a slight disadvantage to those who've got 17p deletion. But in all the other studies since then, which are predominantly in earlier lines of treatment, BTKIs have pretty much ignored 17p as a prognostic factor. So I think if you don't have access to advanced testing, then BTKI is like a very broad spectrum antibiotic for all sorts of CLL. I think the prognostic factor testing actually helps me to choose the very few patients where I can honestly say to them, yes, I may have BTK available, but I think it's still in the best interest to get FCR. And those are the patients who do not have a 17p deletion, who've got RGBH mutated status, where there's a chance of cure. And in those patients, I have a very frank conversation. I say, look, there's a 50% chance of cure with 6 months of FCR, but you run a 3% risk of MDS and AML. What would you like? And some patients would choose chemotherapy. And I still think that, even with all the best treatment in the world, chemotherapy may still be the best treatment for those patients. And others will go for a novel therapy.
Yeah, there are some questions, 2 questions. Question number 1, I have a patient just started on ibrutinib. She had hypertension a day after, mild epistaxis 2 days after ibrutinib, then minimal hematuria 6 days post ibrutinib. Can I still continue ibrutinib in this case?
So really good question. So firstly, hypertension with ibrutinib doesn't tend to be an immediate onset. So it's something that we see that builds up over time. So it tends to build up after about 6 or 12 months of treatment. So it probably reflects poorly controlled hypertension. going into ibrutinib therapy. And in this case, I would spend effort in prescribing antihypertensives to control the blood pressure. Now, the epistaxis and hematuria may well be due to ibrutinib. So I've shown you that it's an extremely potent antiplatelet drug. And you do get minor bleeding at the start. Probably epistaxis and minimal hematuria doesn't bother me very much. It's just like bruising. I would just continue ibrutinib. And in most patients, after 3 to 6 months of therapy, the bleeding will actually get better. The bleeding tends to decrease. Back in the days when we used to test people's platelet function, so we used to bleed people and we test the platelet, and we can see when they start ibrutinib, there's a very clear defect in collagen aggregation. But you retest them a year later, the defect becomes much less apparent. So there's been a compensatory mechanism to compensate for the bleeding risk for ibrutinib. So for minor bleeding, I'm happy to continue. For very severe bleeding, I will sometimes dose reduce to, let's say, 280 milligrams or 140 milligrams. And if someone had actually bled in the brain, I would stop it altogether.
Would you switch to a time-limited option with venetoclax base, or will you switch to acalabrutinib?
So I tend to like to milk a particular treatment pathway for as much value as possible before I go to a different one. So if someone's got side effects on ibrutinib, in general, switching to a acalabrutinib or zanubrutinib, if you can get that, the more specific drugs, in general, the side effect gets better or goes away. And most people who can't tolerate ibrutinib because of a particular side effect can usually tolerate a second-generation drug. Now, if they have ventricular arrhythmia on ibrutinib, I would not re-challenge them with a second-generation drug, okay? But anything less than that, or pneumonitis on ibrutinib, I wouldn't challenge a second-generation drug. But anything less than that, I would be happy to re-challenge with a second-gen drug. And I tend to like to give it. It's very rare that you have got patients who can't take a second-generation drug. They're very easy to take, and I would like to keep that going for as long as possible. And then only when they don't have any more response to second-generation drugs, then I switch to a time-limit therapy like venetoclax. But that's just my personal practice. I want to know that I've milked a particular therapeutic pathway for all it's worth.
So I think for the second-generation drugs, zanubrutinib is coming on board, but for acalabrutinib, I think we just heard from AstraZeneca that I think only Singapore is the one that is routinely available. For Malaysia, Thailand, Vietnam, the commercial launches are already underway, and I think yours should be able to get it, I think, quite routinely, hopefully very, very soon. So I think that's a good segue to the introduction of the new second generations. Suchin, I believe there's another question.
Yes. What is the limit time for forgetting to take BTKI?
I think the question is, I'm just trying to understand what the question meant. But
Yeah,
I think what they mean is, if you forget to take a dose, what do you do? So BTKI works by irreversibly knocking out BTK. So all those drugs only have a 3-hour half-life. But it's like aspirin, it irreversibly knocks out the BTK in the body. So really, if you forget to take a dose of BTKI, the effect still tends to last for 24 to 36 hours before the BTK regenerates. So it's usually not a big deal about forgetting to take a dose. You just take it when you next remember it. Obviously, it's not good to be non-compliant with anything because you start inducing resistance. But yeah, it's useful to understand that the drug actually acts irreversibly, and the time to recovery depends on how quickly your cell type can regenerate BTK.
Thanks. I think I've been reminded that we are just right on time, and I'd like to thank Potam and Prof. Goh for their informative input and in the discussion. Can I introduce the 3 panelists for today? Coming from Thailand, there's Dr. Udom Sak. He is from Chulalongkorn University. And coming from Malaysia, Professor B. Ping Chong, and he's from University of Malaya. And coming from Singapore, Dr. Chandra Molin Nakarajan. He's a senior consultant hematologist and lead of lymphoma and myeloma service at Singapore General Hospital. Welcome to our three eminent panelists. And we're going to have some case discussion, and there'll be cases put on the screen, and we welcome our panelists and of course Prof. Tam and even Dr. Prof. Goh might be hidden somewhere to give their opinion on how best to tackle these new cases. Can we have the question? Yes. So case number 1, 74-year-old patient presented with cervical lymphadenopathy with comorbidities like hypertension, high cholesterol, and history of coronary artery disease with bypass surgery, extensive bulky nodes in neck, axilla, and groin, white cell count of 88,000 with 90% lymphocytes, hemoglobin 11.1, platelet 104,000, flow cytometry typical of CLL, marrow is 70% replaced with CLL, and CT scan reveals widespread adenopathy with largest node 12 cm in mesentery and 8 cm in retroperitoneum. FISH test revealed DELS 11Q, and IGHV is unmutated. I think can we move on? Yes. So how will you gentlemen manage this patient? What would be your treatment of choice and rationale behind it? Where the comorbidities influence the choice of PTKI and why? Prof. Tam, you want to start so we can answer the question and nobody.
No, well, I mean, I'll share my perspective. So the man is 74. He's got a few comorbidities. That makes FCR possible, but higher risk, obviously, because of higher risk of cytopenias and infection. He's got quite bulky disease at 12 centimeters, which is a bit of a risk for tumor lysis and venonuclease. Not that it's not doable, but it's just a higher risk of tumor lysis syndrome. You know, for me, this is someone that in a limited resource country, and he's got 11q deletion CLL and unmutated, which normally goes together. So these people do respond to chemotherapy. They don't do all that well with single agent chemotherapy, but they do okay with multi-agent. So, you know, in a resource limited setting, I would be using either some sort of dose reduced FCR or bendamustine rituximab or something similar for someone like this. But if you can get access to a BTKI, it will be a good choice for someone like this just because of comorbidities. Venetoclax-based therapy is also possible, but a higher risk just because of tumor bulk. So you want to decide very carefully for tumor lysis syndrome.
Can I ask Dr. Udumsa from Thailand, what would your view, approach to this patient in your university, Chulalongkorn?
Yes, I agree with Professor Tam. If the patient can get access to BTKI and can afford the medication due to his deletion 11q and IGHV, I would prefer BTKI. However, in my country, most of the patient cannot afford this medication. So in this patient, I would definitely add the anti-CD20 antibody together with chemotherapy. If the patient can tolerate chemotherapy, I will use rituximab bendamustine. If they cannot tolerate chemo, then I would use anti-CD20 plus chlorambucil. Most of the clinicians in my country don't use FCR in elderly patients. Sometimes it's very difficult to treat this patient in community hospital.
Yes, Dr. Chandramurthy, what was you do in Singapore?
Thank you for the question. I think my choices will be reflective of what I have access to. So while I wouldn't disagree with the choices that have been mentioned, prior, I would probably, so just looking at the two important things in this patient's context. One is the patient's, comorbidities in themselves. Slightly older, probably, though I hate the term, it's one of those slow go patients rather than a no go patient. Second is their potential cardiac comorbidities. And of course, the second part is the risk that the disease brings on. This being an IGHV unmutated disease, quite bulky, as we typically see in the 11q patients. So from both those aspects, you would want to give something that the patient can tolerate early on, but also remain disease-free for as long as possible without the requirement for soon reaching out to a second-line treatments. And both of those conditions are probably satisfied with either BTKI or oral therapy on the longer term, or potentially even venetoclax plus obinutuzumab. Between the two, I think my personal preference will be to go for a BTK inhibitor-based treatment at the present time. And we can argue the pros and cons about these two choices in this particular context. But having said that, even in Singapore, time and again, we do come across situations where patients either refuse to stay on such a long-term therapy, for years together. And going by today's life expectancy, even in Singapore, a man is expected to live about 85. And if they have to think about being on 11 years of daily oral therapy, some patients just plainly say, no, I can't, I don't want to. So I think BR is still a very legitimate choice for this patient.
Yeah, I think it's interesting that you bring up the topic of life expectancy. Malaysia is 78. We just move up from 75 to 78. So this guy technically, 75. So in maybe 3 years he may have some real life-threatening issues from cardiac or what. So I think Benda may be a reasonable kind of choice. What do you think, Professor B? B is from Malaysia, yes.
Okay. So I think most patients can afford BTK going to you, right? In Malaysia. So they go to private hospital. So our hospital, I think most of them can't afford the new agent. So I think for this patient, I will consider rituximab plus bendamustine for this patient. If they can afford, of course, I choose the BTK.
But in the phase, just like to ask Prof. Tam, this patient obviously had a signal for, he's got quite significant cardiac comorbidities. How afraid are you to start BTKI, or you think it's okay,
So I was forced to use BTKI at a time when I had nothing else. So I used it in patients with bad heart disease. I used it in people with heart failure. I used it in really awful patients. And look, on the whole, it's okay. If you use ibrutinib, on the whole, it's okay. You occasionally get patients who have got worsening of atrial fibrillation. Occasionally you get patients who actually have worsening of heart failure. And I pull back on that pretty quickly when that happens. But on the whole, it's okay. It doesn't scare me. Having said that, in this day and age, when the drugs which are less cardiotoxic available, it's very hard to justify starting someone on ibrutinib unless you actually don't have access to the second generation drugs, especially some of risk factors. So this person's had cardiac surgery in the past, they probably have hypertension, they probably don't have a normal ventricle. If you have a choice and you get access to it, I will use the second generation drug in these patients. But if I've got nothing else apart from ibrutinib, I'll be quite happy to use it and just monitor carefully and manage the cardiovascular risk.
Once I had a doctor's father-in-law who has got Waldenstrom and has got AF. So I say, is it safe to give the patient ibrutinib now with the patient AF? He said he already got it. It can't get any worse, isn't it? But he did okay with it. Having said that, yes. Yeah. Can we move on to the next case? I think there's another case for discussion. Okay. Case number 2, 55-year-old patient present with cervical limb lymphadenopathy. So someone younger, extensive bulky nodes in neck, axilla, hemoglobin 10, total lymphocyte count 46,000, platelet 95,000, flow cytometry confirmed CLL. Fish showed del13, sorry, positive. IGHV mutated. He has got no comorbidities. Yes. Let's move on. How will we manage this patient and what would the treatment of choice and rationale behind it? So let's start with Dr. Chandramurthy. You want to have a go at it first? It's a young man, 55-year-old.
Yes, 55 is quite young these days, isn't it?
Yes, yes.
Yeah. So I think this, at least outwardly, this sounds like a textbook patient that would definitely merit a discussion regarding the use of FCR, this being an IGHV mutated patient with no adverse risk features like 17p, p53 or 11q. And as Professor Tam was showing us earlier, there's quite a long potential for disease being treatment-free. So I think we definitely ought to discuss the option of FCR for this patient. In terms of targeted agents, if patient is completely chemo averse and would want to have a discussion on other things, we should equally offer or discuss the options of using BTKIs for this patient. Although, let me just come back on the caveats of doing that in a minute. But of the lot of all the treatment options that Professor Tam was explained to us earlier, venetoclax has probably got the shortest follow-up if we don't, if we class the BTKIs as a group and not separate them individually. But in terms of, the discussion of FCR versus BTKIs, what I wanted to probably put forward, and probably we could have a discussion on that, is if you see with some of the original studies, especially the ECOG ACRIN study, which this patient can be used to extrapolate the discussion on, because this is the kind of patient that would have easily gone on to the ECOG ACRIN study. The patients who were on FCR, only about 2/3 of them had remained on follow-up at the end of the 5-year time point which the trial reported. And of them, they found out that, or they reported subsequently that only 2/3 actually received the full 6 cycles of treatment. So a lot of patients were actually, did not complete the whole intended 6 cycles. So you can guess what potentially could have happened with the survivals if had most of the patients or all of the patients had gone on to it. But you can also argue that it is real life, and we all stop short chemotherapy based on side effects, etc., etc. That's one aspect. Second aspect is also something that I always remind myself, and I actually do discuss this with my patients, is in the ibrutinib arm in the trial, only 2/3 of patients actually remained on ibrutinib at the end of the 5 years follow-up. More than 1/3 of patients actually came out of the ibrutinib or stopped the ibrutinib. And what was more interesting is the vast majority of the withdrawals of ibrutinib were actually not progressive disease related. It was actually side effects related or patient's decision or physician's decision to stop. So you can also argue that, and even more importantly, in those patients who stopped ibrutinib, so those who were randomized to ibrutinib compared to FCR and stopped short of ibrutinib, not staying on it longer term, the PFS was half the whole treatment arm. So the whole treatment arm had a PFS, I think, for about 50 months or so, and then this was like 25 months. So you can argue, and you have to put this to the patient, saying you have nearly a 1/3 chance that you might not stay on ibrutinib, and if you don't, your PFS is expected to be half of what I would expect from the trial. So given that, would you consider FCR or ibrutinib?
Yeah. Just want to ask Dr. Udom, did you is infective risk a significant kind of issue when you use FCR in Thailand? I have 2 cases of cerebral toxoplasmosis from FCR. So my neurologist is very impressed. How come you can pick up toxoplasmosis so fast? I mean, I haven't seen the first case. The second case look quite typical. But what is your experience in Thailand when you use FCR? Do you run into a lot of infective risk?
In my experience, I haven't got toxoplasmosis in my patients. But in community hospital, maybe very few. In our patients, we give Bactrim and acyclovir
Yes.
in everybody who receive FCR. So in my experience, I don't see toxoplasmosis. And in our community, we usually recommend either the young hematologist to really give FCR in very young patient, very fit patient. We don't use FCR at all in older patients who is not fit.
Professor B, what is your experience with FCR in the UMMC? I mean, you might see more of the rural folks coming for treatment. Do you have encounter special issues with infection and so forth?
Recently we are in the registry for registry. So I look at our data. Actually, most of the FCR patients were very long ago. I think for the last few years we started to use R-bendamustine, rather than FCR. So I think for recent years we hardly use FCR for our CLL patient. So experience-wise, some they did have very bad actually neutropenia, and some actually died of sepsis during FCR from our data. But for toxoplasmosis, I don't encounter.
Yeah.
So now usually we advise patients for chemoimmunotherapy for these patients which is young. And most patients actually, some of them actually are very reluctant to have chemo in our local setting. So some of them may choose actually even convulsive plus rituximab, even in our young patient. So sometimes we start on convulsive plus rituximab. If no response, only then we consider again to switch on other treatments.
Prof. Tam, we haven't had conversation on the time-restricted and continuous therapy. Will this be a relevant topic for these young patients? Some young patients are very impatient, they just want to have treatment and off they go, they may move on to something else. What is your feel on this time-restricted or time-limited therapy versus continuous staying? Is it a good thing, or is it that we need still something work in progress and so forth?
Yeah, so I mean, obviously, no one wants to stay on treatment forever, so I would say that the biggest drawback to BTKI therapy is the fact that you're stuck on it pretty much as soon as you started. So which is the reason why there are now combinations of BTKI and venetoclax being developed to try to shorten the duration and have limited duration therapy. So I think that I suspect that the next generation of BTKI-based regimens will all be time-limited by adding other drugs in to make them time-limited. But at this point in time, I think that, in Australia and also in other countries, often we get a choice between venetoclax and BTKI for a given patient. And often, the discussion is that both drugs work. And then the choice is the patient preference. Do you want something that is easy to start, but you have stuck on it long term, i.e. BTKI, or do you want something that is, can be challenging to start, like venetoclax, where you have to come in for blood tests 3 times a week, for 5 weeks to increase the dose. But once you start, you can have a limited duration and come off the drug. And for some patients, especially for some of our patients who live, 4 hours away by car, venetoclax is just not practical. So they start BTKI because they know that although they're stuck on it for life, they don't have to travel for frequent blood tests. Whereas someone else who lives in the city, next to the hospital, who is very motivated, who is young, who wants to get back to to life and have limited therapy, they might choose venetoclax.
I mean, we are still haven't not quite out of COVID yet, though President Biden thinks that we're out of the epidemic. So it does have impact on the use of anti-CD20. How much of precaution, or how much are you No, I mean, we all, I mean, back here we are a bit worried when they give anti-CD20, we render them unable to produce antibody. And of late, we discovered that the silly virus can actually stay much longer in our body and get activated and so forth. So what is your feel? I mean, what's your practice in Australia? Perhaps then afterwards we go around asking the others. Yeah.
Yeah, so we have avoided, we've probably given less chemoimmunotherapy and more novel therapy for precisely the reason, because of the risk of, we don't like the inability to respond to vaccine and potentially prolonged infection with COVID. The one thing that has probably changed the game a bit for us is now we've got good access to EvoShield, which is the preformed antibody. So, you know, we would routinely give our CLL patients EvoShield, especially for therapy.
Dr. Udom, did the COVID change your practice, giving less of rituximab, or you know, are you worried or in your setting in practice?
What is your question again? I'm sorry.
No, because if a CLL patient is given the rituximab, their ability to produce antibody, even with vaccination, is very much impaired. In fact, I think CLL patients themselves have difficulty making antibodies, useful antibodies. So that's in a place where there's still a lot of COVID cases. I think in Malaysia there are about 2,000 reported cases, but we suspect it's more a day, you know. So if they are unfortunate to catch COVID, then we may have a problem. Of course, Professor Tang had just mentioned that we EvoShield that give a safety net, but that's kind of expensive and not readily available yet, as far as I know. I think in Malaysia we can get for very selected patients. Yeah.
That is the problem, because the disease itself, and also I think right now when we use the fludarabine and bendamustine, these two medications also can make the patient cannot produce the antibody. Not only rituximab, but bendamustine and fludarabine. We have seen some case when the patient receive rituximab and bendamustine, the patient when they catch COVID, they cannot clear the virus, and they have the viral in their body for a long time. Fortunately, our government now they have EvoShield, and usually we will give EvoShield to these patients. The government provide this medication, and CLL with rituximab and nucleoside, they can get this medication for free.
Profi, well, how about your practice now? Are you scared to give, or you still giving, or or you protect them? Protect them. Yes, yes.
We are still giving, actually. Yeah. If they need it, I think we have no choice. Yeah. So we just advise them try to avoid crowded places to avoid getting COVID. Yeah. Otherwise, still will give as usual.
Yes. Is Prof go somewhere in the background? Anything that that Prof wants us to discuss?
There's a next question.
Yes.
Could I just mention that we did have a study of immune response assessment in our CLL patients.
Yes.
And what we did observe was the third and the fourth dose of COVID vaccine does make an important contribution in terms of immune response stimulation. So I think it's crucial that we all stress the importance of booster doses of vaccination for our CLL patients, because even in patients who are taking ibrutinib or BTK inhibitors, the first 2 doses actually produces very little response, if any. And following booster doses, they did have a little bit of response.
You're talking, sorry, you're talking about the neutralizing antibody, or even for the T cells, there's both boosted with further booster?
There is data for the T cell responses as well, which we have also looked at. But definitely for the neutralizing antibody responses, there is definitely a response after the third and the fourth doses.
Suchin, there are more questions, Suchin.
Yes, okay. Let's see. Okay. I can't seem to see the question.
Patient was started on CIT.
Oh, yeah, sorry. Patient was started on CIT. This is 1 year later with clinically meaningful improvement. In the meanwhile, he has visited another hematologist and now has FISH report showing del-17p. So now this young man has picked up the new problem. How will you manage the patient now? Will you start BTKi immediately or wait and watch until progression? And how are CLL patients managed in the hospital where the testing facility for high-risk biomarkers are not available? Can we start with Professor B?
Okay. So now the patient has a new mutations.
Yes.
I will monitor the patient if he's asymptomatic and depends on the blood counts of this thing. Yeah. If he needs treatment, yeah, definitely if patient can afford, I'll try to use a BTK inhibitor for these patients. Yeah.
Is there any role for preemptive treatment, Professor Tam?
So probably not. So I'm a bit curious that they came back with 17p deletion in someone who's apparently responding. So I presume this patient must either have residual disease or must be starting to relapse. No, so in general, the 17p doesn't change. Doesn't make me treat someone earlier. But you know, it does mean that when you do treat, obviously you can't use chemotherapy again. I think it's important that you know, as hematologists, we all use our clinical sense to judge how the patient is doing and not rely on biomarkers to frighten us into treating early.
Dr. Chandramurthy, any more feedback on this patient?
No, I think I will start treatment immediately. I will wait for an indication to emerge. It's just, probably the right thing to do. And in terms of the last question, how are CLL patients managed in hospital? Testing facilities and high-risk biomarkers are not available. I think we probably alluded to this point earlier on when Prof. Go was asking the question to Prof. Tam.
Yes.
It depends on what treatment you're going to provide. I think if you're really going with one of the targeted treatments, it probably doesn't matter so much. If you're going to give chemotherapy, then you would probably want to make sure that you're not giving chemotherapy to a high-risk patient. So it probably matters more. But ironically, the places where you're not probably going to have high-risk biomarkers testing are probably the areas that we are going to have consideration for using chemoimmunotherapy, I think. So that is a kind of a difficult situation to answer.
Yes. Dr. Udong, and any more additional remark on this patient?
So yeah, I agree with everybody. I still would wait if the patient is asymptomatic. In terms of the restriction of the genetic test, I would use the clinical data like remission duration to decide for the next treatment. If the patient develops symptoms with like a year, I probably would change to BTKi because the patient has received the FCR, and if he becomes symptomatic within a year or a year or two, I might go to BTKi instead of repeat FCR again.
We'll reserve the last question to Professor Tam. Do you, in Australia, do you all still believe in allografting young relapsed refractory CLL,
Okay, so I think it depends on who you talk to. So I don't remember allografting a CLL in the last 5 years. Equally, I've got colleagues who've done it for patients, where they're afraid of especially patients who are refractory to both BTKI and venetoclax. I've certainly allografted patients who have had Richter's transformation. I think if you get Richter's transformation, different story. You have to have allograft once you get into remission. But no, I don't remember allografting a patient with relapse. And I think that's just because of the therapies that we have available, because we now have third generation BTKI for the ibrutinib, which works really well. And then we've still got the PI3 kinase inhibitors that nobody talks about, but they work. And we have bispecific antibodies, and we've got CAR T cells. So, allograft is pushing further and further down the line. And I certainly wouldn't allograft someone at the start of the first novel therapy. I would consider allografting someone who is relapsed after both lines of novel therapy. But often I'll still try and withhold it for a bit longer, because I really think that effective CAR T cells are probably just around the corner.
Yes, I think our time is up. So I'll leave it for me to thank our distinguished speaker, Dr. Tam, and our panelists for their useful contribution to the discussion today. It's indeed my pleasure to meet all of you, and I would like to thank all the participants who participated and who joined us in this meeting. And last but not least, of course, we want to thank APLC and also the sponsoring companies to Amgen and AstraZeneca, who has taken we're sponsoring this education seminar. And does Prof want to have one last word?
That's fine. Thanks. Thanks
Thank
for
you.
a great job, everybody. Thanks for all your time.
Yes. Thank you again. Good night, everybody. See you all again. Thank you.
Thank you all. Good night.
Thank you.
Everyone.